É uma honra hoje abrir essa sessão, quando, então, nós estamos inaugurando o programa de capacitação em geriatria e gerontologia do Hospital de Clínicas. O serviço de medicina interna foi guindado a uma posição de destaque no hospital após ter recebido novos professores que fizeram um concurso para entrar como professores da Faculdade de Medicina, e nós fomos premiados com 2 geriatras. Com a entrada desses professores geriatras, surgiu a ideia, então, de nós criarmos uma unidade de geriatria no serviço de medicina interna. Então, o professor Emílio Moriguchi, entusiasta, e o professor Matheus Roriz Cruz, também entusiasta de geriatria, se juntaram a nós no serviço e começamos, então, a montar esse programa. O programa está, então, iniciando as suas atividades. Nós vamos ter uma unidade de internação também, específica em geriatria, mas o principal foco inicial vai ser a capacitação dos nossos médicos residentes em relação aos temas de geriatria. Eu gostaria de convidar, então, o professor Emílio para fazer a apresentação.
Doutor Renato, muito obrigado. Boa tarde a todos. É uma alegria estar aqui com os senhores na aula inaugural do programa de capacitação em geriatria e gerontologia do Serviço de Medicina Interna do Hospital de Clínicas. E gostaria de agradecer, em primeiro lugar, o Guilherme, que nos possibilitou a vinda da professora Aleta Borrud para o nosso meio, que ela que é uma geriatra de renome internacional. Eu conheci ela dos diversos congressos que ela dá aulas, e ela é geriatra clínica hospitalar, ou seja, ela trabalha no hospital, ela lidera o serviço de geriatria da clínica Mayo, reconhecidamente uma das melhores hospitais e clínicas do mundo, e lá ela tem uma experiência tremenda em cuidado do idoso. Nós vimos conversando agora na hora do almoço também, sobre como é importante termos noção de como cuidar dos idosos, para que a gente possa realmente oferecer aos idosos o que é necessário e não oferecer o que não é necessário. Então, ela tem um currículo tremendo, não vou ler tudo, né? Então, sorry, I'm not going to read everything here, because you're going to give a lecture. Então, a primeira aula dela vai ser hoje, e vai ser uma aula que ela quer que seja prática, interativa, sobre a avaliação geriátrica global, e como esse instrumento, como esse procedimento pode facilitar o nosso cuidado do idoso e realmente otimizar os custos dentro da internação e também do ambulatório. E amanhã vamos falar sobre delírio. Então, hoje vamos ter essa interação, ela quer que seja uma atividade interativa, que seja interrompida. Ela vai falar em inglês bem devagar, né? E então, por favor, quem não estiver entendendo, interrompam, que ela vai repetir, né? E vamos aproveitar a estada dela aqui para aprendermos um pouco sobre esse instrumento tão importante, nossa prática clínica geriátrica, da avaliação geriátrica global, em inglês, Geriatric Assessment, que é tão, né, é a alma, vamos dizer assim, da ação que nós profissionais de saúde, tanto médicos, outros profissionais de saúde, enfermeiras, nós vamos praticar no dia a dia da geriatria. Please, professor.
It is such a privilege to be here with you all today. I'm so very grateful for the invitation that Dr. Barcelos has arranged, and that comes from Drs. Moriguchi and also Drs. Horis Cruz and Seligman. Again, thank you for being here. I am a geriatrician who went to the hospital because this is where older patients really get into trouble. This is where we need to take the best care of our frail older patients. So this is where I felt as a geriatrician I could best give my expertise and try to share it with everybody in that environment. So I've been doing this now as a geriatrician dedicated only in the hospital practice for 10 years, and we've had many struggles over how best to use our expertise in the hospital at Mayo Clinic, and I'm going to share with you some of the lessons that I've learned from that experience. So what I want to be clear on is that when we talk about geriatric assessment, there are dozens of assessment tools. I'm not going to do that. I'm going to talk about what I know in a busy hospital, what adds the most value to the patient, what is the most critical, and then how to, again, use our expertise, our kind of minimal resources we have as geriatricians being few to the great numbers of patients in the hospital. Now, there was a study that came out in the 1990s from the Harvard Medical Practice Study that looked at adverse events in hospitals, and that was a breakthrough in medicine in the US. There was a report called "To Err," meaning to make a mistake, is human. And so this was the first time where we started looking at adverse events or errors in the hospital. And from that report, they estimated that maybe 4% of all patients will experience an adverse event in the hospital. But then Rothschild broke it down between patients who are over 65 and patients who are under 65 years of age. And the older patients will have 2 to 10 times the number of adverse events in the hospital. You can see here's the older patient. This is a surgical event. This is a medication event, a diagnostic test event, and falls. But that's only the events that we tend to measure, you know, in the hospital. There's all kinds of things that happen to older patients that are not considered adverse events, but actually have bad outcomes for the patient, such as delirium, which I'll talk more about tomorrow. This is a very important study that came out in the 90s that said, well, when a patient comes into the hospital, what is their capability? Can they bathe themselves? Can they walk independently? So Mark Sager measured these things on entrance to the hospital or in the week before hospitalization, and then looked at what functions could they do at the time they dismissed. And you can see that there's this huge drop-off in patients' abilities during the hospital stay. This is an adverse event. When a patient cannot go home and do the same things they did before they came into the hospital, you know, that's an adverse event that we need to figure out how to improve on that or find the resources to help the patient. We know that for every day in the bed, a patient loses at least 5% of their muscle strength. So that compounds day by day. So we know if you look at the number of falls that occur in the first 2 weeks after a patient leaves hospital, it's 5 times that might happen if you look at then the rest of the next 3 months. So most falls happen right after discharge because of the loss of muscle strength. That's an adverse event. So when we talk about, in the US there's this expression, a sentinel event is a terrible medical error that occurs in the hospital. And for an older person, even coming in the hospital is in fact a sentinel event because of the things that happen, you know, in terms of the loss of capability. And really, at the end of the day, most older patients know that we can't fix them, but they at least want to go home and enjoy some of the same functions they had before they came to the hospital. So they have, in some ways, more realistic goals than we do. What they need from us is to make sure that they go home and they can still function in their environment and don't end up permanently in a rest home. Most older patients, that's their goal. So I just asked this question in general, you know, what is the best predictor of the outcome of hospitalization in an older patient? You know, there's a lot of studies looking at prognosis for older patients. And probably you'll already guess what I'm going to say of these items. You know, oftentimes a patient comes in the hospital and the intern will list the diagnoses. heart failure, diabetes, chronic lung disease, but really it's what predicts their outcome is their functional status before they come into the hospital. What can they do? Are they independent in their home? And in fact, that sums up the impact of all these diagnoses. When I, as a geriatrician, want somebody to present to me, what I want to know, they live in the community, they're independent, they manage their own medications. That tells me how good they are. So, and in fact, in the critical care literature, there's a lot of interest in this because, as we all know, the ICU is a precious resource and an expensive resource for the hospital. So how can you determine when a patient enters the hospital what the likely outcome is of that ICU stay? Because ICU stays, the outcome is not very good for frail older patients. We can see this, there's something called the Lawton Index that sort of is an index of all these things. Can you toilet yourself, bathe yourself? If you have at least 5 of those functions intact, your survival is much better than patients with less of those functions intact. So that is probably the most important predictor of what happens in an ICU stay. So these are some of these, when we talk about the functions, these are the functions that we measure in an older patient. The Katz was the one who first kind of listed these, and they're called the activities of daily living. So we know that poor function predicts, the outcome, and it means it also predicts worse function at the end of the hospitalization. So these are the frail elders. When you see these patients, these are the frail ones that need the most intensive care to try to maintain their functional status. And will likely, in our hospital, we know when they come in that they are going to need a rehabilitation stay after our acute hospitalization. They might go to a subacute nursing home, a less acute facility to do their rehabilitation before they can go home. So I love this study that Hansen did that looked at, what are the best predictors of all of this? Of all these functions. So if you can follow me here, he takes all patients and he breaks them down into those who have dementia and those who don't have dementia. And he said, okay, what percentage of patients who recover their activities of daily living that we just went through before, what percentage of those will recover their function after hospitalization? Of the demented patients, only 13% recovered. So dementia is a very important predictor of poor outcome. So then the patients who were not demented, then you go down, do they need to use a walker or a cane in their home? Some patients need to use it outside the home, but do they even need to use it in their home? Those who needed to use a walker in the house, only 15% recovered their activities after the hospitalization. Okay, for those who don't use a gait aid, and then you come down, is their walking impaired? Meaning that they have difficulty getting up from the chair, it's very slow walking, you turn around, you sort of lose your balance, and you come back. Do they fail that test? Those patients, only 7% of those patients recover their function. So you can see, really, almost dementia and mobility are probably 2 of the most important predictors of outcome of the hospitalization. So what I want to talk about really are these kind of aspects of the assessment that I find are most helpful in the hospital, taking care of my frail elders. The cognition, we'll talk about delirium, And I want to talk a little bit about medications, because I find that this is probably one of the most important things I can do for patients, is take away harmful medications and also not prescribe harmful medications in hospital. We talk about mobility and then just the self-cares that we just mentioned. So when we talk about cognition, there's really three aspects. There's the question of dementia, delirium, and then there's this other one about capacity. Can they make their own decisions? Do they have that capacity to understand medical information and help to make decisions for themselves? I'm often asked that question. And just to say, this talk is so relevant for you. I hear this so much from even my very brief time here in Porto Alegre, that the aging population here is really growing, exploding. You know, this comes from the US database, but you can see that the group that is growing, that has the fastest growth, is really the oldest. But that all older patients, that population is growing very fast in Brazil. So it's very important in terms of what you do here in the hospital to understand this. And then within that, we know that as you age, the percentage of patients who are demented grows as well. It's, you know, probably 30, 40 some percent by the time you reach your mid-80s. What I find to be the most useful test to screen for dementia in the hospital, because it really takes about 3 minutes. And, you know, as in the hospital, we don't have 20 minutes to do cognitive testing. We have 3 minutes. You know, and this is very good test. It's been well validated. It's the mini cog, it's called. And so what you do, you ask a person, you want to make sure that they have registered 3 items. So I just say apple, table, horse. Say it back to me. So they will say, you know, if they cannot learn those 3, you know, then they're probably already demented or delirious if they don't have the attention to learn 3 items. But if they are able to register it and say it back to you, then you ask them to draw a clock face. You don't give them the circle, you ask them to draw it, because of course then you know if they draw something so small, you know they're demented. They don't understand that they have to draw it big enough to put a face in it. So you ask them to draw the clock, and you ask them to set the time on the clock. And then with this test, if they cannot recall any of those 3 items after having drawn the clock face, they're probably demented. If they can remember maybe 1 item, then you look at the clock face. Is the clock face normal? If the clock face is normal, then they're probably not demented. But if they can't recall any, and the clock face is abnormal, they probably have dementia, and then you send them to Dr. Horace Cruz to confirm that, that they have dementia. So this just shows you here that this is one of the oldest tests to the Folstein Mini Mental State Examination. Is a very famous short test for cognition, but the mini-cog performs about as well and takes 3 minutes versus 20. So this is just an example of a clock face that is clearly abnormal. You know, your assessment is qualitative, meaning you just look at it, you and I know it's normal or abnormal. So the important thing about a clock test is it tests a very important part of patients' cognitive function. It's what we call executive control, the ability to make higher level decisions. You know, the ability to do more than one step command. You know, so that they draw the clock face and have to put the numbers in the right place. So it's a higher level decision-making function. And we know that if you perform well on the clock test, it correlates very well with your driving ability and your capacity for independent living. So for a very brief cognitive screen, it performs very well. So you're going to send a patient home from hospital, and you want to know, can they manage their medications, their insulin? This would be a very good screen to give you an idea as a screen whether they can do that. Okay, so one of the passions I have is the question of delirium in the hospital. It's one of the most devastating complications of hospitalization for an older patient. You know, a lot of patients come to us already delirious. You know, they have a urine infection or pneumonia, and they're, you know, delirious, but quite a number will also develop it in the hospital, and most of the elders who are in the ICU will have delirium from their ICU stay. And the important thing as well is we do not recognize it. You know, if you go to patients afterwards and patients and you talk to them, they will admit that they were confused, but we don't screen, so we don't see. So this is one of the important things here, is that we need to screen. And why do we need to screen? Why do we need to look? Because this might be the very first sign of something, your patient is unstable. I mean, we recognize when a heart rate is 120, we recognize when their respiratory rate is 40, but, you know, the brain is a very, for an older patient, a vulnerable organ. It's it's another organ system. So we need to recognize that this might be one of the most important signs of an evolving problem in the hospitalization. So there was a very nice study that came out a couple years ago. It was a meta-analysis. It looked at all the available high-quality studies looking at prognosis after an episode of delirium. And this is quite profound because it looks at, within the next 2 years, what is the outcome of one episode of delirium. And it was also, it used a population where there was screening of people's cognitive and physical function before they were hospitalized. So we already had their pre-hospitalization, you know, there was some information about pre-hospitalization function. So you can see that the risk of death is doubled within the next 2 years. The risk of being in a nursing home or an institution permanently is 2.5 times, but also the incidence of new dementia, new onset dementia that wasn't present before the episode is very high. You can see it's over 12 times the risk. So Sharon Inoue, who did this as a fellow at Yale and now is a full professor at Harvard, developed the confusion assessment method as a way to screen for delirium. It's been validated in numerous studies around the world. It's the most commonly used screening test for delirium in the world, the confusion assessment method. It's something that once you start using it, you can use it at the bedside, and I can look at my patient and I can say, delirium, yes, no. Once you get used to using it, it doesn't take very long to use it and to learn it. So one of the issues is this been an acute change? Is the mental status fluctuating? And again, tomorrow I will talk more about how you actually implement it if you come to the talk at noon tomorrow. But just briefly, is the patient inattentive? You know, it's the patient that they're in the room, a cart goes down the hallway, or people are talking outside the room, and, you know, they kind of startle. They're distracted. Is their thinking clearly disorganized? Do they think they're in their cousin's house? Do they think they're at church? I mean, people will tell you, you know, that you know this. We all recognize this. And then maybe the patient is hyper alert and agitated, or maybe they're just vacant. Don't really answer, just kind of empty. So it spans that spectrum. So in order to make a diagnosis, you need, oops, sorry, I keep pressing the wrong button. You need this one, and either this or that to make that diagnosis. And this is interesting. I use this occasionally just to see how people are recovering from their episode of delirium. You can see here's that clock drawing test again. And here, day one, couldn't perform it, but you can see they're starting to recover from this episode. You know, you can actually sometimes see in the hospital stay doing the clock drawing test that people begin to recover their cognitive function. I'm going to change topic now. This is an actual case of mine where I purposefully did not write for a sleeping pill for my patient. But in the middle of the night, the nurse calls the person who's covering for me, who is not a geriatrician, and says, "Oh, the patient's not sleeping. Can you please write for something?" So the lady gets Zopiclone, you know. And then 3 hours later, she climbed over the bed, you know, fell, broke her ankle. So I come the next day to my patient and I say, "What happened to you?" Well, she said, I always take paracetamol at bedtime because I have my arthritis. And that's all she wanted. So what I bring you to is the whole question of medications, because I think in terms of assessment of the elderly, this is one of the most important things we can do is prescribe appropriately for our older patients. You know, I look in the U.S. and as, you know, as only 13% of the U.S. population, the elders, and this was even years ago, make up half of the days in the hospital, but they spend the most money on drugs, and more than half of them are taking a drug for which there's no real good reason for them to do it. So Dr. Moriguchi and I were talking today that one of the things he does on behalf of his patients is stop these unnecessary medications, okay? And we know from Shelley Gray, 15% of older folks will have an adverse drug event in the hospital. So this is something that I think I communicate to my geriatricians to begin to bring to your colleagues here, is in the US, there's something called the Beers List. There was a recognition in the 90s by Mark Beers that there was a whole bunch of medications that are dangerous for older patients. And so he formed this list, and over the last 2 decades, since 1991 when it was published, it's used in the US as the most important standard for prescribing of medications to older patients. So, in fact, the federal government, when it looks at nursing homes, care facilities, they look and say, well, how good is the prescribing? Does it meet these standards? And it uses this Beers List to determine that. So it's very important that people who care for older patients become aware of this list. And this list is found, and I talked to Dr. Moriguchi about it, and I think that you all can begin to look here. The list is in this organization. It's the American Geriatric Society website. And adapt it so it's appropriate for the medications that are used here. And so then the importance of it is when Donna Fick, who updated it, and Mark Beers is now, who formed it, is now dead, but Donna Fick has taken over, and she updated it, you know, in 2012. She did a study where you look at what happens in the next 30 days after a patient gets one of these medications. This is the risk of an adverse event after getting one of those medications. You can see, you know, the risk of a fall and a hip fracture, you know, delirium, you know, sedation, excess sleepiness. The risk of it's 3 times, 4 to 6 times, and then problems with bladder function, and then fall, dehydration and syncope, bleeding. So I went to the World Health Organization site where they talk about the medication formulary for Brazil, and I tried to put this up here for you so that you can begin to recognize some of these medications here from the formulary here in Brazil. I give you a minute to look over them. I won't try to say them in Portuguese. And your geriatricians will help to disseminate, give this to you. And again, this is the website. So let's talk about mobility. One of the most commonly used tests of mobility around the world is something called the timed up and go. And I mentioned it before. Can you get up from a chair without pushing off, shoving off on the arms? Can you get up? Can you walk 20 feet, turn around without falling over on the turn, come back and do that in 20 seconds? If it takes more than that, it's abnormal. One of my physiotherapists, I had a lady who came in with a fall, bad knee. I said, whoa, she thinks she's tilting to the side. Can you look at her? And she said, well, the tug, T-U-G. The tug was 6.5 seconds. Okay, she's good. That was helpful, but she did that for me. I find in the hospital, actually, most of my older patients can't even get out of the bed. So this is helpful if you've got somebody who can do that, but the vast majority of my patients can't get out of the bed. So one of my colleagues at Mayo has devised another screening test called the iMove. And I actually brought some copies, Dr. Moriguchi, and this is a reference. And this is really helpful because it goes from I can't even turn over in bed to I can walk independently in the hallway. Because you need a better gradation, you need a better scale for how your patient is moving. If they fail the timed up and go, there's a long way to go from laying in the bed to passing that. So, and in fact, our cardiovascular surgery service is now using this at Mayo to assess whether patients are ready for dismissal to home. And they actually have iPads, the patients, where they assess themselves as a motivator to say, I'm good enough to go home. I'm now here, So I leave that with you because this is actually more helpful to me. It's something, every day the patient can help you, the nurse can help you. It's not something that I need special equipment to do. So that's why I say, the timed up and go, it's good for people who can walk, but you need this measured distance. Whereas this iMove, it's quick, you can see progress day by day. It's a very nice tool. So now I get to the point of how do you actually do this? I think us busy physicians know that all of this assessment, takes time to take really good care of old patients and to keep them safe takes time. We can't do it all. This is where we look to all our colleagues in nursing, our rehabilitation, pharmacy. So really what I say is we really need to have good communication, with our colleagues. It's very important to work as a team. It really improves the care. So these are the people that I find help me the most on a day-to-day basis. I don't have pharmacy here in this list, but in fact, I have a pharmacist who I talk to many times a day about prescribing in my older patients, who understands the issues of prescribing. In fact, he came to me to get the beers list from me. Okay, so how do you make it happen? There's a lot of different ways to do this in the hospital. You know, there's been a lot of trials, and I know that you are in the process of developing a geriatric unit. I think it's really helpful because the most frail patients, it not only takes the best care of the most frail patients, but I think it also helps you develop the expertise. It's a place where other people can come and learn the expertise. You can figure out what works for you. What you can develop the programs there. It's like an experimental unit that then you figure out how do you bring this, because we know there's more than 13 patients in this hospital who could benefit, you know, in terms of a unit. So what I found at Mayo, we had a geriatric consult service that got abandoned. And in fact, the experience is that most people don't follow your recommendations. If they're not under your direct control, they don't follow your recommendations. So there's the program, and some of you, I know when we talked to Dr. Horace Cruz and I talked, there's the HELP program at Yale that Dr. Inoue, who developed the confusion assessment delirium screening test, developed. And what's very interesting about it is it says, okay, it's not based in a unit with a few physicians. It's a program that we have across the board in the whole hospital. It's a screening program that we incorporated into the care of all the patients in the hospital. And especially maybe in medicine where you're the most frail, older patients. It's an example to me of how we have to think in terms of safety. You know, there's not enough geriatricians in the world to care for all the old patients. So how do we help our colleagues provide that best care? This is an example where what they did is on admission, they screen every patient for factors that we know or characteristics of the patient that we know pose high risk for delirium. So then they don't have a physician do it. They have somebody who is maybe not even a nurse, because nurses are a precious resource. They have somebody who is maybe a master's level come and they screen, they figure out who's high risk, and then they prescribe therapy to that patient on the ward. And so it might be get this person a pocket amplifier because they can't hear you. Make sure that somebody comes and helps feed this patient that can't feed themselves. Make sure that the nurse walks this patient 3 times a day. So it's a program that is based not on that the doctor doesn't have to think about it, the doctor doesn't have to prescribe it. It happens automatically, you know. So I love that example, and I think this is somewhat what we have to strive for. It's not easy. And in fact, you know, the HELP program has been, and I'll talk more about it, has been disseminated all across the U.S. It saves hospitals millions of dollars, but you need people who are passionate, who are dedicated. So, you know, in your group, you find out what is the biggest issue for you, who has the most passion, and what issue are you all most passionate about? Then you'll be successful. If you do one thing and you're successful with it, then you go from there. But at Mayo, we don't do the HELP program, but we have another type of program where, as part of the nursing assessment every day, where nurses might assess their skin, for instance, and you know, their cognition. They also do delirium screening with a CAM twice a day. This is part of the screening that happens at Mayo in the hospital. And the way that they also have a tool where you look at what's their level of awareness, you know, called the Richmond Agitation Sedation Scale. It's what triggers the CAM. If they're not alert, then they do the CAM. But then also, and we'll talk more about this tomorrow, is that the nurses, it was a nurse who was passionate about this. She was a champion at Mayo. But then the nurses came and said, well, why would we do this if I tell the physician, your patient is delirious, and the physician says, so what? You know, the physician has to have an appropriate response to that. We have to work as a team with the nurses. So we developed a management order set that helps the doctors figure out what to do. Okay, so, you know, I like to use the example, Lucian Leap at Harvard was one of the first patient safety advocates in the US. And he talked about the example in anesthesia. They have this thing that everybody should be equivalent. Everybody provides the exact same care. You know, I think in some ways we try to do that at our hospital. We use a lot of order sets. We have to make it simple for us to do our work. So we have a delirium management order set that tells you, okay, what are the most common causes of delirium? What do I need to investigate? How do I treat this? And also at Mayo, I was part of doing that, but we also have a geriatric admission order set. There's a lot of things like sleeping medications, pain medications that should never be given to older patients. So it's helpful if on admission we have an order set that says, okay, these are the best things that you give people for their bowels so that you don't give them renal failure, you don't give them delirium, you know. So we have already set, you know, things to take care of pain, nausea, you know, bowels, and it's in the whole system, so everybody in the whole system can use it. And it provides safer care for our older patients when everybody who's old should get an order set like this. It's a way of sharing the expertise. Okay, and then in our hospital too, you know, one of the things are, you know, people will get fluids and 3 days later they're in heart failure and you wonder why the fluids are still running. Well, the nurses can actually we have protocols where nurses can take out the bladder catheter, can stop the IV fluids. So we again respect the expertise of our nurses and give them the prerogative to do the things they know when they're there at 10 p.m., at 10 at night, for the patient. Okay, and then one last thing I want to say is there's this daily checklist. This is very important. This is something that in the U.S., I think it's the Institute for Healthcare Improvement, you know, the safety organizations, we talk about checklists. For older patients, it's very important. We round at the bedside, in the room with the nurses every day. When we come into the room, the nurse who cares for that patient is at the bedside. And so then we talk over the care plan together so that the nurse hears it, I hear what her concerns are, the patient hears it, we look together. And so we say, okay, is the patient been out of bed? Do we need physiotherapy to come and walk this patient? Let's get him up to the chair for meals. You know, what's the plan for the day? When I talk about, we use this this helps us with the alphabet because it helps us remind us, you have to develop what works for you, clearly, in Portuguese. But when I talk about binders, we're talking about things that tie people down, that are unsafe. You know, people talk about bladder catheters being a one-point restraint. You know, patients, you know, they get up, they're unaware they have it, the next thing you know, they pull the catheter out and they've traumatized their urethra and they can't pee. So, you know, we talk about removing these things, you know, every day, and then we talk about whether they're delirious. We make sure, because older patients are at higher risk than other patients for getting venous thrombosis, you know, have they moved their bowels and bladders? And in fact, you know, when we talk about the debilitated elderly patient, what I find is that the bladder gets debilitated as well. The bladder loses its function in the hospital, and so they're ready to go home, and in fact, they're not emptying their bladder. So, these are the things that, I always say, geriatrics is not what we call rocket science. It's just, you have to mind all these details to keep your patients safe, but it's very important. And then, are they eating well? And then, what is their goal of care, and are they going to go home? Let me see. I'm sorry. I'm getting close to the end here. So we do the daily checklist at the bedside, but we also sit down with in a larger group every morning, and maybe it takes 10 minutes to cover 10 patients, 12 patients, but we do this with this group. Now, another thing that I would like to say is the whole question of the handoff when a patient leaves. This is one of the most dangerous points for an older patient is when they leave the hospital. We know that about half will have a medical error after discharge, and a significant percentage of those will result in a bad event that sends them back to the hospital, and most is a drug event. And so this comes from the United States, but one of the key issues, as we know with older patients, they have the lowest level of what we call health literacy, their understanding of medical issues. Maybe about a third will, this is maybe 5% will have an excellent understanding of medical issues. Maybe a third will have a moderate understanding. Basic means they might be able to tell you when they're going to see the doctor again, but that's about it. And then 40% are completely deficient and can't tell you what their medications are for. So this is a huge issue. So this gets back to the whole, in some ways, capacity for decision making. There's another initiative in the US that we're trying to implement at Mayo called Teach Back. It's really, you say to patient in a common language, can you, this is what these medications are for. And then you say, can you tell me in your own language, what did I just tell you? What is this medication for? So that you assess what their understanding is. Why are you here in the hospital? This is important to assess that capacity then for them to be able to go home and do self-cares. Very important safety measure. That we talk in real language with them. It takes time, but it's going to save you in the end. They're not going to come back to the hospital if they understand their self-cares. So what we say, it's patient-centered, it's research-based, it improves the patient's cooperation. The patient is more likely to follow your instructions if they have an understanding, and you've tested that understanding. And it reduces this risk of an adverse event. So finally, the last thing I want to just briefly talk about is, and we've talked this morning with Dr. Moriguchi, the whole question of end-of-life care, because it's part of, I think, what I'd say the important assessment of the older patient is what kind of care does this patient truly want? A patient comes in, they're septic, they're critically ill, the train can be speeding down the track and they're in the ICU on a ventilator, but maybe that's in fact not what should have happened. Maybe, or Dr. Moriguchi talks, they come in with angina, their kidney function is very marginal, and the next thing you know, they're in the cath lab getting angioplasty, and then they're on dialysis. So, I try, when the patient comes in, to really ascertain under what circumstances do you want care. If you're going to end up in a nursing home, no, I don't want that kind of care. If I can go home, yes, do this. But if I'm going to not develop dementia or, impairment, don't do it. So it's very important when patients come in to have that conversation about goals. And in fact, this study, the support study, is that we most often understand what the patient actually wants. 30% of families have been unhappy with the communication with their doctors about this. 25% of patients died in pain, and then only of all those that really want just good, I don't want to suffer, I don't want to suffer, only 30% got that kind of support at end of life. So palliative care, and I know you have a palliative care initiative here, that's very important. It's one of the groups that I work with the most. I do a lot of hospice care in the hospital. So, and just to say that in the US, we use something called, as a way to structure that conversation and document it, we use something called the POLST, you know, physician's orders for life-sustaining treatment, you know. So it structures this conversation to go through what does the patient value, what does the patient really want for themselves, you know, and then make sure that the caregivers, whoever is going to make decisions for that patient, if they can't speak for them, understands that. And we document it. Very important to document that in the record somewhere. I document it in the social history because that's the one that that's never done. And it ends up in the chart forever if I document it there. So, you know, you find a way that works for you as a way to make sure that those preferences get known to your colleagues and for the future. Okay. In Minnesota, we have a specific, every state has their own, but where I come from in Minnesota, these are the elements of the POLST form in Minnesota. Okay. So the basic question is, if there's no pulse and you're not breathing, do you say, it was my time, it's okay? If we come and there's no breathing, no pulse, some patients will say resuscitate, but then you have a conversation that maybe 5 to 8% of you will leave the hospital. Once you have that conversation, most people will say, oops, sorry, don't do that to me. You know, if realistically only 5% are going to actually leave the hospital, and that's the 18-year-old, not the 90-year-old. So you have that conversation, but if the patient is still breathing, because this often happens, they're in respiratory failure, do you say, I can make you comfortable. I know that you will not suffer. Or a lot of my patients who are pretty functional will say, you know what, send me to the ICU for non-invasive, for CPAP, what we call non-invasive respiratory support. We'll go, you know, to the ICU for that, and then there's going to be some who say, doctor, do everything. But you walk it through with them. And then these are these other interventions depending on, you know, where the patient's at. And if they have metastatic cancer, then you actually have these discussions about antibiotics and nutrition, because we know that these are not likely to be beneficial for this patient. So then you go back to, I can make you comfortable. And so then we always just document, who did we have this discussion with? What family member was in the room? And who is their decision maker? Who does the patient nominate as the person to make decisions for them? And then as well, if the patient can't speak for themselves, then you say, well, we're going to fill this out. Maybe the decision maker fills this out, but it's based on what we know they wanted or what we think is in their best interest. Okay? So this is something that when I get patients who I know have unsolvable problems, we get the palliative care team and we fill this form out so that when we send them from the hospital, they don't come back to the hospital for things that we can't help them with. We get them hospice, either at home or in a nursing facility or a hospice facility. And I can tell you the satisfaction of the patients and their families is very high. It's very high when we do this and walk through. And so these things take time, but this is about the value of this kind of geriatric and, you know, people who are passionate about geriatrics, what we bring to the system. It takes time right now, but it saves expense and time later. It's very valuable. So then we have to document these things. Who do we talk with? What order am I going to put in the chart? Who decides? And are there any other things like no tube fittings? Do they want to go to the unit? You know, et cetera. So just kind of in summary, I would say when I started with the group of geriatricians 10 years ago in the hospital, we were so ambitious. We were going to do 20 different assessments. You know, we were going to do all these things, and we found that, in fact, the hospital got busier and busier, and our patient load got higher and higher. The patients are sicker and sicker. And so then we figured out what we need to do, what's most important to do for the patient. And what I would say to you is, don't be overly ambitious. You figure out what's most important for you, what is going to, and we have, it's an expression, I don't know if it will translate to you, but you figure out what's the low-hanging fruit that's easy to pick. You don't go for the thing on the top that needs a ladder. You say what's easy to pick, and what is going to have the greatest impact. Maybe it's medications. Maybe it's getting therapy, more therapy services. Maybe it's doing this end-of-life care discussion. But you start somewhere with the thing that is going to have the biggest impact for you. And then also the other thing is, what is your expertise? Who can help you? What expertise you have? Maybe you start there. You know, Dr. Horace Cruz, with his background in neurology and, you know, dementia, delirium, neurologic issues, you know, you work with the expertise you've got here. And then you also need, like I said, the champion who is passionate. You know, at Mayo, we were able to do the delirium program because we had a nurse who would do anything to make it happen. That's what you need. You need a champion, people who feel passionate. And then you need all your team on board. You know, you work as a team. Okay, and then order sets. You make it easy. At Mayo, we also have sepsis order sets because you've got the intern who, you know, the septic patient who's, you know, this is what you do. These are the fluids. These are the antibiotics. This is the vital sign. Get the lactate. So it makes it easy. You get the order set. You know exactly what to do. And so make it easy for yourself, okay? So I'm ending here. You know, Robert Palmer is a geriatrician who has had a lot of long experience in the hospital and feels very passionate about hospital care. And what he said is, though, you know, usually with most patients in the hospital, you don't think about what their function is going to be after they leave the hospital. But for the older patient, this is critical to their quality of life, their ability to be independent. It's critical to the cost of care and also the outlook, you know, the prognosis among older patients. There we go. I'll leave it back there. Thank you again. Yes. This works.
Pessoal, pode fazer perguntas em português que a gente traduz. Vamos aproveitar que o professor Aleta está aqui. Eu convidaria o Renato para fazer parte da mesa, o Matheus e o Guilherme, para a gente poder abrir para este início da atividade do programa de capacitação em geriatria e gerontologia, né, para que a gente possa aproveitar a vinda da professora aqui. Ela vai falar amanhã sobre delírio também. E eu acho que seria bem interessante se a gente pudesse aproveitar bem, né, a estada dela aqui. I'm open for the questions for people to... Se alguém tiver alguma pergunta, é só levantar a mão que tem microfone. Ele vai te levar o microfone ali.
Eu vou falar em português e tu traduz, Murilo.
Yes.
Bom, a respeito da... Eu acho que um item que a senhora destacou, que eu acho muito importante, é a respeito das medicações usadas e dos eventos adversos dentro do hospital. A gente vê realmente uma lista enorme de medicações que são potencialmente inadequadas para paciente idoso. E a gente, eu acho que...
He's talking about medications in hospital it's not adequate for the elderly.
Bom, eu acho que quanto a listas de medicações, eu acho que elas realmente têm um valor, mas também tem um certo receio de que elas sejam tomadas de maneira absoluta, principalmente em pacientes que já vêm usando elas há muito tempo. Então,
When there's a list of medications, he's feared that they could be taken absolutely, and some patients already comes with those medications to hospital.
então eu acho uma coisa a gente não prescrever inicialmente um antidepressivo tricíclico, e outra coisa, como a gente vai se posicionar num paciente que já usa há 15 anos e agora é idoso, com 70 anos, suspender ou não suspender. Eu imagino que a gente não deva aplicar essas listas de maneira tão absoluta, sim ou não apenas.
So do we have to be careful not to take this absolutely, because some patients comes with antidepressives, and you know that you cannot prescribe, but you cannot take it out. So could you answer?
Yes. You're right, that is a bit of a difficult problem for the patient who comes to you. And, you know, I'm fortunate in that I'm working in a system where I can provide good communication back to the providing physician. That's when it's very important to have the discussion with the patient, because there will be times where I will talk to the patient and I say, this medication really I don't believe is good for you. It is likely to cause you to fall. It might have been good for you when you were 55, but now that you're 75, amitriptyline, for instance, might have been good for you at 55, but now that you're 75, it's likely to cause, you know, all of these problems. I'll list them. And so oftentimes I find that patients will say that they really actually don't want to continue the medication. So then it's a question of, how do you need to taper the medication, or can you recommend a safer alternative for them? I find that patients very often will be very happy, the patient themselves will be very happy to get off of medications that they wonder are in fact safe for them. My father-in-law was prescribed Zopiclone. He's not able to walk. My mother-in-law says, you know, he's not getting better. He's sleeping all the day. He's confused. So then we worked out a taper for him. But you know what I mean? It's one of those things that the patients themselves often know that they're suffering the effects of the medication. And so then it's a question, I think you probably have to work out what we say politically or diplomatically. How do you communicate that to the home physician or whoever prescribed the medication? Frankly, I do that a lot. I say, on the dismissal summary, I say, I discontinued this medication because the kidney function doesn't permit safe use of this. I discontinued this medication because this patient has gait instability and this is likely to cause falls. I have to say somebody has to help the patient, and I do it, but it has to do with your ability to communicate and whether there's a physician on the other end who can get that information and understand your reasoning. You know, I think most people have the patient at best interest, the best interest of the patient at heart. It's a question of being able to have appropriate and professional communication to the other physician.
Thank you very much.
Obrigado, mas amanhã a professora vai participar do round ao beira do leito com a equipe da doutora Bia Seligman. Então, eu vou pedir para ela que esteja pronto com a lista dos medicamentos que os pacientes estão tomando, que ela tenha essa biolista aqui dos medicamentos e acho que vai ser interessante.
I have a question for you. Eu vou falar, I will talk first in Portuguese and after I translate. Nós temos, falando acerca da Avaliação Geriátrica Global, Comprehensive Geriatric Assessment, nós temos uma revisão Cochrane, a Cochrane Revision, a meta-analysis, published, if I don't make a mistake, about 2 or 3 years ago, yeah. On comprehensive geriatric assessment. And esta meta-análise Cochrane, ela encontrou, publicada também no British Medical Journal, que, então, este método que é, né, como o professor Moriguchi coloca, uma das essências da geriatria, está associado não com a menor mortalidade, né, em si, a longo prazo, mas com alguns indicadores secundários, como menor rehospitalização, lower readmissions, and especially, but also também melhor a capacidade funcional, né, a médio e longo prazo, lower readmissions and lower and better functional capacity. Yes. Exactly. So, like, I think this is one important point for non-geriatricians to understand that essa era a evidência que estava faltando, né? This, even though doesn't have a direct impact on mortality, there was a trend. Havia uma tendência, então pode ser que, né, seja demonstrado, mas ao menos diminuía significativamente o número de rehospitalizações, né, e a médio e longo prazo dava mais independência ao idoso. Nós temos um exemplo típico, we talked yesterday, that o paciente que é admitido e fica uma semana sem caminhar, o pai do professor Moriguchi, o professor Yukio Moriguchi costumava dizer que o idoso ficar alguns dias acamado já sai do hospital sem conseguir caminhar, né, professor? E isso é um problema aqui, nós temos uma deficiência em fisioterapia motora. So, like, how is your impression at Mayo of the impact of comprehensive geriatric assessment? And my second point is, when do you stop enteral feeding? This is probably even a more difficult question. Quando a gente deve iniciar e quando a gente deve suspender a alimentação enteral, né, seja por uma sonda nasentérica, que no caso de demência, né, nunca deve ser usado ad eternum, que aumenta o risco de pneumonia, não tem evidência que aumenta a sobrevida, pode aumentar o risco de aspirações, e quando a gente indica um procedimento mais definitivo, como uma gastrostomia, jejunostomia, que também não há comprovação que aumente a expectativa de vida. So, if we don't have evidence that jejun tube feeding or a gastrostomy will increase survival and even can increase the risk of pneumonia, for example, enteral tube feeding. So, which points do you consider when you indicate tube feeding and you recommend to stop tube feeding?
Okay. I will answer the first question about comprehensive geriatric assessment. We do not, there's nobody that does comprehensive geriatric assessment at Mayo. But within, I think most of us, whether we're in the clinic or in the hospital, do more targeted assessments. Targeted assessments, especially in the clinic, where there are geriatricians who are sent because of specific problems, and then you target the assessments. However, I will say that there was a very lovely study, Sid Bogardus from Yale, I'm talking to my colleagues here now, where in the geriatric assessment clinic at Yale, they had a protocol where they followed a standard protocol of assessment, and they picked up far more geriatric syndromes amongst highly skilled geriatricians than if they did not do a standardized, protocolized assessment. So I think it depends on what your resources are. I think what you're saying, Mateus, is that there is a value for the most frail. For most of the best outcomes for the use of geriatricians comes from the people, not the people who are so debilitated that nothing you do helps. And it's not for the young old who are well. It's for the people who are somewhat fragile and likely to end up in a skilled care facility and who actually have the most to gain from an assessment. And those are the people that we know that we spend the most effort to ensure that we do no harm and that we press for full rehabilitation and do more comprehensive assessment. Now, the question of feeding, I have to tell you, I can't remember when I've asked for a feeding tube. I think that oftentimes they might be most indicated in a patient who's just had a stroke and has dysphagia, cannot swallow, and has an unsafe swallow. And so then if patients will get a feeding tube while we see what their recovery will be. But in the patients who have just dysphagia because of their functional decline or dementia, or have end-stage cancer, again, dementia, we get our palliative care service by because we know that this is not likely to increase their survival, and it also will not provide quality of life for the patient. And in fact, some of my frail patients, I think, probably going through the procedure to put a feeding tube may actually worsen their swallowing function and cognitive function and actually cause harm to them. So I think then it gets to the discussion, and that's where the palliative care, and I guess you call it the bioethics, to come and say, what will most benefit the patient, and also for the family. Oftentimes we're treating the family and not the patient. So if for the family to understand that the patient won't suffer if we withhold, feedings at end of life, it's very important for family to have that understanding. Now, we have there's patients who have dysphagia, and what we try not to do is put a feeding tube in, but we have our occupational therapist work with radiology to do assessment of the swallow, and then we prescribe a diet that's safe for them. If the diet is not safe for them at all, most patients will end up eating for comfort anyway. So at that point, we essentially develop a contract with that patient and family to say, if eating is more important than anything, then and you're going to get pneumonia as a result, then we will just try to treat you at home, and we're not going to come back to the hospital or in your nursing home. So we have a contract. That's what we do. So literally, I can't remember when I put a feeding tube in. So we've avoided that question because it's usually not helpful.
Para nós é difícil, né? Para a pessoa que trabalha na emergência, que estou vendo aqui, também na UTI, nós temos muitos pacientes idosos com sonda nasentérica, e com essa resposta, assim, a gente tem que desenvolver a nossa cultura, mas e a gente como geriatra tem muitos pacientes que pós-AVC, acaba indo para casa ou cuidando em casa com sonância entérica. E é uma experiência difícil, eu não sei. Doutora Beatriz, você podia dar o seu depoimento como clínica?
Thank you very much for your explanation. I don't think the real discussion is where to put or how to put a feeding tube. Most of the things you told us were very important. For me, especially the 3 minutes mental examination, that will help us a lot. But we are struggled with a very different reality. We don't have nursing homes here. The patients, one of our patients is a 22 years old patient, and he's completely able to go home, but the family can't come here to pick him, because if they leave their home, their places will be taken off by their neighbors. So it's a very different reality. We are struggled every day with different realities. And in a way, this discussion about feeding is quite not real. We are faced with so many other very important things. We don't have this contract either. We don't. Most of our patients are in the hospital and they could be somewhere else, but we don't have this place, we don't have this background, the system doesn't have it. So it's quite something very, it's a luxury way of looking, and in a certain way, even geriatrics, it's a luxury. You see, if I look at and see what is important for this patient, is he able to go home walking? No, we can't wait until they are able to go home walking. We can't do that. We have to put them on discharge earlier, because there's a big line of people waiting for their places. So I don't know, I think most of these discussions are hard talk to us, very hard. It's an ideal place to discuss, but we are faced with such a different reality every day, and you'll see tomorrow, you'll figure tomorrow. It will be a very pleasure to talk with you with that, and you are all invited if you want. But the 3 minutes mental examination, precious. Thank you.
Oh, thank you. Well, I'm very aware of the demands been made on the street, that one of the demands is that the public health services be appropriate for the resources that this country now has. You know, it's because you have an aging population, and you're going to have to figure it out. You know, most of us in the U.S., all the children are working and can't care for the parent at home. So the family structure is now a situation where there needs to be other resources to care for the frail elders. Yeah. I appreciate that very much.
Eu acho que essa realidade, eu vou comentar em português depois em inglês, tá? É exatamente, acho que por isso que nós temos que ter o nosso serviço de geriatria e gerontologia, porque nós vamos fazer a geriatria e gerontologia do nosso meio, né, de criar o nosso, adaptar os instrumentos para a nossa realidade e treinar os nossos jovens profissionais de saúde para a nossa realidade, e a gente mesmo ler os artigos interessantes, importantes, mas também adequar à nossa realidade. E acho fundamental essa discussão, né? Então, agradeço a Bia essa reflexão, porque acho que é por isso que nós estamos aqui, estamos começando esse programa de capacitação, como diz o nome, Geriatria e Gerontologia. I'm saying that this is a real nice opportunity to exchange ideas, because we really live in different realities. And we are starting here with geriatric capacitation program and the geriatric unit, and we are going to base on evidence and based on our reality, make what's the best for our elderly.
One last comment to your colleague. One last comment. And Dr. Moriguchi and I this morning were talking that it's always with us geriatricians, our patients do stay in hospital longer, but if we have the opportunity to provide care to them, we can maybe prevent some bad thing happening that will cause them not only to come back, but lengthen their hospital stay by 3-4 days. So if we can have the time to work with the patient perhaps and have an understanding that maybe our patients, older patients, stay in hospital longer, that if there's a recognition that we are providing safer care, that in the end they will actually probably leave hospital sooner because we have not done something that's set them back while they're in the hospital. So I think that's important for the hospital administration to understand.
Hello. I would like to make 2 remarks about today and your talk and our very particular political place we are now. I think you came at probably the most sensitive time for doctors in Brazil in modern history. Well, we feel right now unbelievably abused and taken away our freedom of choice by our current government. I don't think we've ever been so unhappy and aware of how population can be, I don't know, for lack of a better word, abused by political situations. And I think what Professor Beatrix meant is that we are lacking in so much structure that it seems hard for us to do something ideal. But I would like to say that it was very important to hear you say you need someone passionate. And I think for geriatric services here to be great, and it can be great, it needs more than papers. I think if this service is started with a lot of passion, and we have that in our Latin countries, I think it will be beautiful. And sorry if we are particularly sensitive and upset. I think you came at a very, special time here. So I please hope you understand our sentiment right now. And thank you for pointing that out, especially coming from such a, a rich country in scientific production that is the US. So I would like that to be the remark for not just the geriatric service here, but all the other services. I think sometimes when you don't have structure, you need to hold on to passion. So thank you.
Ok. Eu gostaria, primeiro eu vou falar em português e depois eu falo em inglês. Eu gostaria de lembrar que esse aprendizado dos cuidados dos idosos, ele não é uma coisa que está competindo com o nosso quadro social. O quadro social é dramático no Brasil e a classe médica está realmente sendo muito pressionada. Mas o aprendizado de lidar com o idoso vai ser em qualquer momento da situação econômica e política do país. Então, eu acho que aqui, o Hospital Universitário, é importante que a gente tenha treinamento para identificar precocemente os riscos, tentar encaminhar de uma maneira adequada os problemas, mesmo que a gente não consiga todas as soluções. Mas, se nós conseguirmos diminuir o sofrimento do nosso paciente, identificando quais são as coisas importantes para ele, e com isso a gente pode, então, ter desfechos melhores, mesmo que não conseguirmos uma clínica especial geriátrica ou uma um lar mais adequado, pelo menos a gente vai tentar que o paciente volte para casa na melhor condição possível. Então, nós vamos fazer a nossa parte como médicos e tentar, como aqui é um hospital universitário, a gente vai tentar que os nossos médicos jovens aprendam a melhor forma possível e depois adaptar dentro do que for a realidade do momento. Hein? Ok. Tu quer traduzir? Okay, I'm telling. We have a very difficult social problem in Brazil. We can't solve these problems in our hospital, but we have to learn how to take care of our old people in any situation. When we are good and when we are bad, we have to identify the problems of our patients and try to find a better way to take care of them. This is a university hospital, so our young doctors have to learn the best possible, and then they can customize the best with the reality of the country and the patients and the families. That's what I said. Right? That's it?
Well, we all work within constraints. My world is imperfect too. We have a lot of resources, but I have little time. So I think, probably the one thing you might have is time for communication and collaboration with your team. That you can do a lot with that,
Professor Beatriz Seligman, you know that I admire you so much as an internist, one of the best internists I have ever come to know. Yeah. But I have to disagree with you. I think I agree completely with your husband, Professor Seligman, that yes, we have problems, but I think your presentation is compatible with adapting to Brazilian reality. I agree also with Professor Moriguchi. And our slogan, let's say, the shift of view, comparing, I'm also an internist, and I'm praised to say that. I think that instead of prolonging admission to discharge the patient walking, our paradigm is the other, is shortening up admission in order to the patient go back still walking. Yeah. It's a different paradigm.
Obrigado. Alguém tem mais alguma pergunta? Eu agradeço aqui, vejo geriatras de colegas, né, de outros hospitais, outras instituições. Eu não sei, Guilherme. Nós temos amanhã uma aula sobre delírio, né, uma forma de otimizar o atendimento do paciente idoso aqui no hospital, que eu acho que é um tema bastante importante e interessante. E também gostaria de agradecer aqui também a presença do pessoal da unidade Álvaro Alvim, né, e porque nós temos uma ideia de trabalhar também naquela unidade. Então, acho que estamos começando, né, e agradeço principalmente ao professor Seligman, porque foi ele que nos deu a abertura para começar com um programa de capacitação em geriatria e gerontologia, que foi bem recebida pela VPM. Agradeço ao Guilherme também, a professora Nadine, e estamos começando com isso, e isso tem que ser uma construção de todos nós, e que estamos aqui, e peço colaboração de todos que estão aqui, né.
Apenas para fazer um convite, embora esteja super em cima da hora, a Aleta, na verdade, veio para o Brasil para participar de um evento no Rio, que vai de quinta a sexta-feira, que é um evento sobre segurança do paciente, que chama Safety 2013, então, www.safety2013.com.br. Ainda daria tempo, quem tiver interesse. São 2 dias de evento sobre segurança do paciente.
Bem, como estamos chegando na hora prevista, gostaria de agradecer em nome do serviço, do professor Renato, e do programa de capacitação geriátrica e gerontologia, a presença de todos e convidar todos para amanhã estarem aqui às 11 horas, desculpe, 11 horas, das 11 às 12, aqui nesse mesmo espaço, para ouvirmos sobre delírio, né, um assunto extremamente importante, manejo do paciente, manejo prático do paciente com delírio no hospital. E convidar todos que colaborem com a gente para que a gente possa realmente começar com um bom programa de capacitação geriátrica e gerontologia. E desejo a todos um bom envelhecimento, uma boa tarde. Obrigado.